Hello, everyone, and welcome. I'm Andrea Tarr. I'm the SCAN Program Director, and I want to welcome you and thank you for joining us for our first ever virtual Meet the Doctors event with our very distinguished panel of doctors from Monmouth Medical Center. A couple of pieces of information. I want to let you know that at the end of the, later on, you will be getting an email with contact info for everyone who's on the panel, so you don't have to worry about writing anything down. We're also recording this, and you'll also get access to that. And then I just want to direct everyone's attention to the chat function at the bottom of your screen. If you have a question that you would like to ask at the end, you can just put it in the chat. No guarantees. We'll see how our time goes. We will do our very best to answer as many questions as we possibly can. All right, now I would like to introduce everyone to Marybeth.
Hello, everyone. I'm Marybeth Kwaminski. I'm the program coordinator at SCAN. I would like to introduce Dr. Heliotis, who is our moderator for today's panel. Dr. Heliotis is Chief Medical Officer at Monmouth Medical. So Dr. Heliotis, thank you so much for moderating today. And if you can kindly share what your role is as Chief Medical Officer at Monmouth Medical, that would be wonderful.
Sure. Thank you, Marybeth, and thank you, Andrea. It's a pleasure to be here today, and every year I look forward to this as we really enjoy entertaining all of your questions. So before I introduce the panel, I'll just tell you a few words about my role as the Chief Medical Officer here at Monmouth Medical Center. I have the responsibility of overseeing all physician performance, and that means really monitoring how our physicians take care of safety. Safety is a big, important aspect of everything we do today. We want to make sure that not only are our patients safe in the care that we deliver, but also our employees. So our physicians and our hospital, as well as our system, has committed to being a high reliability organization. And safety is #1 in our list. Secondly, I take a hard look at quality in terms of how the practices of all the various specialties are being performed here at the hospital. We use evidence-based medicine and best practices to form processes and pathways to make sure that our patients are receiving the most up-to-date and best care possible. In addition, I oversee the regulatory requirements for the hospital in terms of the medical staff, and that includes CMS and various organizations like our Joint Commission. So basically, I am the liaison between the medical staff and administration. And it is with great honor that I would like to introduce our panelists today. We have Dr. Angi Priya, who is, I'm sorry, Dr. Priya Angi, I'm sorry, Dr. Angi. She is a geriatric and internal medicine physician at Monmouth Medical Center. And as a geriatrician, Dr. Angi has 21 years experience, and she specializes in the unique needs of the elderly, which I think is very critical today. And these needs of the elderly include chronic diseases, nutritional problems, skin ailments, cognitive loss, memory impairments, and immobility and balance problems. Dr. Angi did her residency at Monmouth Medical Center and did 2 additional fellowships, one at New Jersey Medical School and also one at Hackensack University Medical Center. She is board certified in internal medicine, and we welcome Dr. Angi.
Thank you. Thank you for having me.
Our next panelist is Dr. Randy Shafferts. Dr. Shafferts is a practicing vascular surgeon. He is currently our Regional Director of Vascular Services of the Robert Wood Johnson Barnabas Health Southern Region, which includes Monmouth Medical Center, Monmouth Medical Center Southern Campus, which is located in Lakewood, and Community Medical Center, which is located in Toms River. Dr. Shafferts, his clinical interests lie primarily in peripheral vascular disease, carotid disease, and venous disease. As a primary affiliate of Monmouth Medical Center, he has done his training and residency at Albert Einstein Medical Center and his fellowship at Robert Wood Johnson Medical School of Vascular Surgery. And Dr. Shafferts is board certified in vascular surgery. Welcome, Dr. Shafferts, to our panel.
Thank you, Dr. Helio.
And our third panelist is Dr. Bert Parcells. Dr. Parcells is a practicing orthopedic surgeon, practicing with Seaview Orthopaedics. And he is a Monmouth physician who specializes in osteoarthritis, joint degeneration, post-traumatic arthritis, joint pain, and performs surgeries for total and partial knee replacements, direct anterior hip replacements, hip preservation surgeries, general orthopedic surgery, and hip reconstruction for metastatic cancers to the hip and pelvis.
Thank you for having me.
Dr. Parcells did his residency at Rutgers, Robert Wood Johnson, and his fellowship at Bern University in Switzerland. And that was in adult reconstruction and preservation fellowship surgery. So we welcome Dr. Parcells. I think we have a great variety of physicians here who are experienced and leaders in their field. So as we start today's meeting, I would like to start with Dr. Angi because I've had the opportunity to collect many questions from the community, especially from our seniors who are great readers of medicine and of interest and try to take full responsibility for their healthcare. So I have a series of questions I'd like to go through. I think it covers a wide variety of topics. And we'll start with Dr. Angi. And one of the questions I get many times, not only in meetings such as this, but even in the community and people who are not in a particular conference is, Dr. Angi, what are the benefits of seeing a geriatrician? And at what age does one consider seeing a geriatrician? Because I already had in the past a primary care physician.
Yes, yes. So the geriatric, the age cutoff is 65 years or older. So all our patients in our office are 65 or older, all the seniors. So what is the advantage of seeing a geriatrician or a internal medicine or a family practice doctor is geriatricians have additional training related to all the various geriatric syndromes, like, as you mentioned earlier, memory problems, dementia, depression, or urinary incontinence, osteoporosis. And not only that, we do in our office what's called comprehensive geriatric assessment, which includes not only their medical problems, other things like vision problems, hearing problems, balance problems, because falls is a huge issue in seniors and they end up having fractures. And if an 80-year-old has a fall and a fracture, the prognosis for that particular patient is very poor. So we kind of try to prevent the falls, provide physical therapy or occupational therapy early on so that we can avoid that. And our goal as geriatricians is to keep these seniors in the community as long as possible on as minimum medication as possible and as independent they could be. And as we always believe in geriatrics is any medication that we start, we have to start on a very low dose and we kind of go on very small increments. So the thing is you start very low and you go very slow. And most of the time when you treat these patients, it's not actually the age. You could have a 80-year-old who is like functionally very independent and their functional status is very good. In that case, the 80-year-old is just, 80 is just a number, it doesn't matter. But if you have another 80-year-old who has like mild to moderate dementia and he or she has other issues where they are dependent in their ADLs or IADLs, you treat them little differently. Your management will be little less aggressive than somebody who is functionally independent. So we kind of get the overall picture of the patient rather than addressing one issue. The other thing that we often see and address is polypharmacy, which is very frequent in elderly. They come into our office with a couple of sheets of medications, and every time we see them, we kind of, can I take away one medication? If I cannot get rid of a medication, can I at least reduce a dose of a medication? You're trying to kind of decrease the medication. The less medication they get, the better they are going to. These are all the areas that we get additional training when we do our fellowship in geriatrics.
Okay, thank you, Dr. Angi. you mentioned fracture, so let me jump over to Dr. Parcells. I think a question that's on a lot of our seniors' minds is when they start to get knee pain, what options are there to treat that knee pain? And if, as an orthopedic surgeon, if surgery is an option or a consideration, at what point does that become something that they should seriously entertain? And if that's the case, is there an age limit? In other words, can an 80 or 90-year-old undergo knee replacement? And how do you evaluate that? Can you expound on that, Dr. Parcells?
Sure. So the broad view of knee pain kind of in an elderly patient is first looking at the status of the cartilage in the knee. And when people wear out cartilage, they develop osteoarthritis, which is a very, very common issue. And you just see, I see dozens of people every single week in my office coming in with arthritic type pain. The goal is to address the pain by being as least invasive as possible. You see, I have the advantage of treating a condition that is not life-threatening, and so we never have to jump into doing any sort of surgery. I do believe kind of in the body's ability to heal and to kind of get past certain inflammatory flare-ups. And I see in many ways my job is to kind of help the body bounce back from an arthritic flare-up, or to kind of find ways to optimize a knee's health so that we can kind of stay out of the operating room. A lot of different options are available for that, and those include physical therapy, where you're spending time to build the strength of the muscles around the knee and also kind of improve flexibility. And that goes a long way to improving kind of your natural walk and your ability to kind of get up and down out of chairs and up and down stairs. And that really does reduce knee pain significantly. Other things that we work with are medications like anti-inflammatories. We can do cortisone injections, which reduce inflammation. We can do gel injections, which also reduce inflammation by adding lubrication. One of the newest kind of treatments that we offer are Prp injections. The way this works is that you're kind of casting this broad net by drawing blood from someone's arm. You take about 50 cc's and you spin it down in a machine to isolate growth factors, and then you place that into the knee to kind of supercharge the body's ability to heal kind of any sort of injuries. And I do think that all of these techniques work very well. The presence of arthritis is so significant that even though I feel like I significantly treat people for arthritis and probably prevent 9 out of 10 people from needing joint replacements, I'm still doing 4 or 5 joint replacements every single week. So just to give you an idea of how prevalent arthritis is in the community. What I would say about age is that it's kind of just a number. We're really looking at a patient's overall health and their body's ability to tolerate this 1-hour procedure. We've done a lot to kind of reduce the risk of complications, and a knee replacement today is different than a knee replacement 20 years ago. If you're just though to ask me, what is the number? I say that patients over the age of 80 are generally a little slower to recover from a knee replacement. That's not to say that like an 83-year-old couldn't benefit and couldn't do very well with one, but that's, I think, the kind of the number where we start to really look long and hard at what are the pros and cons of the procedure.
Okay, that was great. Thank you, Dr. Parcells. I'd like to jump over to Dr. Shafferts and ask a general question, Dr. Shafferts. What conditions do you commonly treat as a vascular surgeon?
So vascular surgeons treat a variety of disease processes, but most commonly we treat diseases of the arteries and the veins. With respect to treating venous disease, I see a lot of patients with either leg edema or leg swelling. I treat patients with varicose veins, and also with blood clots in the leg, which unfortunately is a significant problem. On the arterial side, we treat a variety of diseases. Most of these diseases are related to two things, either development of aneurysms in blood vessels or development of plaque inside the blood vessels, which can block flow to certain areas of the body or potentially cause other complications, such as stroke, if it happens in the arteries in the neck and the brain, or peripheral vascular disease. Most vascular surgeons, the majority of their practice involves treating diseases of the arteries. So they'll treat patients with stroke who have blockages in the carotid arteries in the neck. We'll treat patients with aneurysms in their abdominal aorta, which is in the abdomen, and diseases in the legs, which primarily is blockages of the arteries in the legs due to plaque buildup, similar to what you would get in the heart. In addition to the arteries and veins, we also treat patients who need dialysis. So we frequently put in either catheters for immediate dialysis treatment or grafts or fistulas for patients who require long-term dialysis treatment.
So, Dr. Shafferts, let me ask you a question. You cover a lot of arterial and venous disease conditions. So how would someone who has some mild symptoms, they have aches and pains in their legs, but nothing really debilitating, how would they proceed in terms of knowing whether they have something that could potentially be serious in the future? I mean, you know, how do you screen these type of people, and who should be screened?
All right, so first of all, I think the initial evaluation should be done through the primary care physician. The initial evaluation should involve a complete history and then a focused physical exam on the legs to see exactly what you can find on an examination. Frequently, a good history and physical will be able to delineate leg pain into several categories. Most common complaints would be either swelling or discomfort when you walk, or joint pain, or sometimes even back pain. There are several conditions that overlap symptomatic-wise with peripheral arterial disease. Most commonly is spinal stenosis, arthritic disease, as Dr. Parcells has discussed, osteoporosis, osteoarthritis, and sometimes arterial disease in the legs. Beyond initial evaluation by primary care, there are several ways we can evaluate patients non-invasively. There are several studies that can be done either through our vascular lab, either an ultrasound or other non-invasive vascular studies, which can easily diagnose disease without having to do anything invasive. I would estimate that probably 50% of the people I see for quote unquote leg pain, which may be due to vascular disease, is actually not vascular disease. So I do evaluate a lot of patients that I end up sending to other specialists once I rule out a vascular problem. I think the vascular surgeon is uniquely situated to be able to distinguish between vascular issues and non-vascular issues in the leg. So I don't mind screening patients who think they may have a vascular problem.
Okay, thank you, Dr. Shafferts. Returning to Dr. Parcells, a question I have received, I think, which is on many seniors' mind, is hip replacement. Can you discuss that a little bit and let us know, you know, I think their big worry or troubles will probably get in the office many times is, you know, will I be able to be active after the surgery? And if so, how quickly?
Yeah, that's a great question. I should start this by saying the hip replacement is my favorite surgery. I think it works better than any other surgery in orthopedics. I mean, I'm biased because this is what I went into, but it's also why I went into joint replacements. You're essentially removing the arthritis and replacing the damaged area of the hip with a ceramic and titanium ball and socket. And we've gotten very good at being able to replace the arthritis without causing significant injury to the surrounding muscles and tendons that are around the area that will kind of be inflamed or can get scarred down or stiff if they're damaged. And the big part about recovery is getting active early. And I will tell most of my patients that they should expect to be up and walking the day of surgery. I work very closely with the anesthesia team, and we go to great lengths to make sure that when patients wake up, they're not in much pain. As I do the surgery, I'm injecting kind of a long-acting numbing medicine that really provides comfort for about 2 days after the surgery. There is a recovery time. So the surgery is about 60 minutes, so it's not a long surgery. Most of my patients are being discharged the day after, so we like to keep everyone in the hospital for a day just to monitor them, make sure they're waking up well from the anesthesia. And then they head home, and their goal is to be working with physical therapy to kind of regain their coordination and their balance and their strength in that leg. When they're recovered, there's basically no restrictions on what you're able to do. These implants have gotten very good in terms of their stability, and they last 25, 30 years. And so for most people, that's their lifetime. And so the goal of doing the surgery is, again, it's not a life-saving procedure. It's a lifestyle procedure so that you can get back to everything that you were doing before you had all this pain.
Great. Dr. Parcells, one of the questions that I see asked very often, since you're talking about hip surgery, is a lot of people want to know, and they hear this from colleagues, from other people who had surgery. What is hip resurfacing?
Yeah, so that is a procedure that has become popular probably in the last 20 years. It's a variation of a hip replacement. So when you're doing a hip replacement, you're essentially replacing the ball and the socket. Your hip is a ball and a socket. And the socket gets replaced the same way in a hip replacement or a hip resurfacing procedure. So the real focus or the differentiation is with how you address the ball portion of the hip during surgery. With a hip replacement, you are completely removing the ball and you're replacing it with a ceramic ball. With a hip resurfacing procedure, you're only shaving about 8 millimeters of the kind of damaged cartilage off of the ball, and then you're kind of putting a cap on top of it. So the advantage there is that you're removing less bone and kind of allowing more of the native hip to remain. And so people, I think, recover maybe a little bit faster from that procedure.
Okay, thank you. It was good to know the difference between that, because I get asked that question many, many times. Thank you.
Yeah.
Returning to Dr. Angi. Angi, how can seniors practice good preventive health as they enter their 70s and 80s years of age? What suggestions would you have for them?
Okay. So probably preventive health for seniors, I think I would put it in 3 different categories. First is seeing their doctor periodically and getting their annual checkups done. And basically getting the blood work, making sure the blood pressure is fine, the blood sugars are fine, kidney function is fine, cholesterol is fine. That's the checkups from the doctor and the blood work. The second category, I think, is getting all the immunizations. For example, annually, they are all supposed to take the flu shot. And then the pneumonia shot. The pneumonia shots are 2 kinds, the 13-valent, that's the Prevnar 13, and the 23-valent, which is the Pneumovax. So if somebody has taken these shots before they turned 65, they're supposed to take the shots again after they turned 65. Usually we give the 13 valent and we wait 1 year. In the following year, we give the 23 valent, that's a pneumovax. So because seniors are like 10 times more prone for pneumonias than people who are less than 65 years of age. So this is strongly recommended. And the other immunization that we talk about to our patients is a Shingle Shot. So for the past probably like 2 years, we have the new Shingle Shot, that's Shingrix. It has 2 doses, which have to be taken like at least 2 months apart. Maximum you can go is like 6 months apart. If you cross 6 months, then you have to start the series again. But it's only one time you take it, both the shots, then you are done. And the third category is the screening. That's breast cancer screening, pap smears, colonic cancer screening. So usually the cervical cancer screening that we do with the pap smears, usually if the patient had no atypia in the past, no problems in that area, then it stops right at 65 years of age. But if they had issues in the past, then it goes on. Similar thing with breast cancer. We usually screen patients till they are like 75, unless they had a history, personal history or a first degree relative who had breast cancer, then the screening goes on beyond 75 as well. Colonic cancer screening, similar thing. You start at 50 and sometimes in 40 if you have a first degree relative, and it goes on every 10 years. But sometimes we don't have to do the whole colonoscopy. I mean, a lot of people might have watched in the TV about the Cologuard. It's simple. It's like 98% sensitive and specific. You can do that. And the other thing is the Dexa Scan. That's a bone density test, especially for women and some men with other medical problems. We do that, which determines the density of the bone. And depending on the number that we get from the Dexa Scan, we calculate what's called FRAX score, and which helps us who can have to have a full-fledged medication for osteoporosis, or who can have just the vitamin D and calcium. And the other thing that I would suggest is the ultrasound to rule out AAA, that's aortic aneurysm. Dr. Shafritz can talk about it more, because we do that screening. Anybody who is elderly, who has a history, he had a history of smoking, they all should get an ultrasound to rule out aortic aneurysm. Those are the various things that we offer, the appointments with your physician, the immunizations, and the screenings. If you address all these, I think you can keep up good health.
Okay, thank you, Dr. Angi. Dr. Shafferts, let's get a little more specific. I know you touched on it generally on the first questions about what conditions you treat, but what are the common signs and symptoms of vascular disease that our audience should be on the lookout for?
So common symptoms of peripheral, let's start with the legs. So, because that's probably the most common thing that we evaluate. So the common symptoms of someone who would have blockages in the arteries in their legs would be pain when they walk. The pain could be in the thigh or it could be in the calf. Most prominently, it's in the calf muscle. And basically, the pain is muscle pain, and it occurs because the muscle's not getting enough oxygen when it's active. Frequently, the pain only occurs during ambulation or walking. It does not occur at rest. It can occur at rest, but that would be very advanced. If it occurs in the thighs, it usually presents as a burning type pain in the thigh muscles, and it will prohibit walking. So if a patient walked a certain distance, they would get this complaint, and it would pretty much happen at the same distance every time. It would be the same pain, and when they stopped, it would go away, and then they could continue walking again. It's due to blockages in the arteries that supply blood to the legs. The blockages could be in the arteries in the abdomen, or they could be in the arteries in the legs themselves. That would cause that problem. So for the other signs, I guess, of peripheral vascular disease in the legs would be potentially pain at rest, which would occur in the foot, not the leg. And that would be relieved by standing up. Frequently at nighttime, they'll get it when they lay down to sleep. Their foot will hurt. And if they hang their foot off the bed or stand up, their pain would be relieved. That would be a sign of severe vascular disease in the legs. If we're talking about venous disease, it would be swelling and pain and throbbing and aching in the legs, and seeing the presence of visible varicose veins in the legs. As far as signs and symptoms of other diseases in other locations, unfortunately, a lot of them are silent. Disease in the carotid arteries is usually not symptomatic at all until it causes a stroke. So the main presentation of a patient with blockages in the arteries in the neck that may lead to a stroke is unfortunately either getting a stroke or having a TIA, which is a mini stroke. Weakness in an arm or leg, numbness of an arm or leg, inability to speak for a few minutes is a common symptom. Also, loss of sight in one eye for a short period of time. That's also a symptom of carotid artery disease. Unfortunately, these things are usually asymptomatic, even if they're advanced, until they present with a symptom. Dr. Angi also mentioned screening for aneurysms in the elderly population. So unfortunately, aneurysms are usually asymptomatic until they rupture. So there really are no symptoms of an aortic aneurysm, which is why it's very important to do screenings. What is a screening? A simple physical exam and an ultrasound of the abdomen will be able to detect an aneurysm. When do we fix them? Aneurysms usually get addressed surgically when they get to about 5 centimeters, which is about 2.5 to 3 inches. Doesn't seem that big, but aneurysms can rupture when they get to about 5 centimeters. Below that, they usually do not. Anybody with a history of atherosclerotic disease or risk factors or a history of smoking should be screened for an abdominal aneurysm at the age of 65, like Dr. Angi said. Medicare will pay for a screening ultrasound at the age of 65. If you have a history of smoking, I think it's more than 100 cigarettes, or have an atherosclerotic profile. So if you have hypercholesterolemia, hyperlipidemia, hypertension, those things will lead to vascular diseases.
Okay, thank you so much, Dr. Shafferts. Dr. Parcells, what is arthritis?
Yeah. So anytime you hear the word itis at the end of a medical word like laryngitis, that's inflammation. So itis is inflammation of the kind of specified part. So arthritis simply refers to inflammation of a joint. And kind of within that broad category of arthritis, there's two main subcategories. There's inflammatory arthritis, like rheumatoid arthritis, which is caused by like an autoimmune condition. And there's a lot of different conditions that fall in this category. And your body is just prone to developing inflammation. Its immune cells are overactive. And so you see this very typically in younger people, and they just get swelling and pain in their joint without any sort of injury. The more common type of arthritis, and the one that I would say I see more than 90% of the time, is osteoarthritis, which is basically a description of cartilage loss. So we all have cartilage that lines the ends of our bones, and it's a shock absorber and a lubricant, and over time it just wears out. And our bodies really don't know how to reproduce it. And when it wears out, you start to develop pain and inflammation in a joint.
Okay, thank you, Dr. Parcells. Dr. Angi, what are the worrisome signs of forgetfulness?
So a lot of patients that come to our office, they come with this chief complaint of not being able to remember things. Sometimes it's the patient themselves, and sometimes it's the family, the son or the daughter. So, I mean, as we all age, the lag time to recall information may be a little more, but that shouldn't be interfering with your day-to-day life. So if somebody has memory problems which are interfering with how they live, or like simple things like, for example, they have been driving to the store or the supermarket for n number of years, and lately they get lost, even going to like 10-minute drive, they get lost, or they can't figure out how to use a remote, which they have been doing forever, or they can't do their laundry because they don't know which one goes first, which one goes next. So whenever there is an interference with day-to-day life because of the memory problem, that is something serious that needs an evaluation.
Okay, thanks, Dr. Angi. I think going along with that, a lot of questions I get from patients and from the community is over-the-counter supplements.
Mm-hmm.
Can you comment on that in terms of the elderly? I mean, if you see these commercials for you, this is going to improve your cognitive abilities. It's going to improve your memory. There's a lot of products out there making a lot of claims.
Sure.
So in your practice, because you deal with the elderly so much, are these supplements of value? Should our seniors be taking supplements?
So pretty much every week, there are like 2 or 3 or maybe 5 patients who come up with this literature on these things from Google, or somebody next door neighbor gave, or you saw something in the TV, can I use it? So all the time, pretty much, I say there is no value to this. But sometimes they want me to review the label and say, is it safe for me? Can I take it with the other medications that I take? Then I go through the ingredients, and if I feel, yeah, they are safe, but do they add any advantage to your memory? I don't think so. But a lot of times we had, not lately, probably like maybe 5-6 years ago, everybody was pushing for coconut oil. It was like a miracle. If you take coconut oil, your dementia is gone. That's the notion that they were believing in, but not lately. Lately, I hear about Prevagen, ginkgo biloba, and things like that, which I don't encourage. But there are other things like vitamin B12, which we know it's involved in the neurological function. And vitamin D, though vitamin D is more related to your bone health, we also know it's important in cognitive function. So when we do blood work on our patients, we do check for these levels, and if they are deficient, we supplement them. But other than that, over-the-counter supplements to improve memory or other things, I don't encourage them.
So there's been really no medical evidence or data to support the efficacy of using them, right?
Not really. Mm-mm.
Plus absorption becomes a problem too. A lot of these supplements are not really absorbed.
That's
so
right.
You don't really know how much you're really receiving systemically.
Yes.
So I want to go back to the arthritis again with Dr. Parcells. And we know that, most of us will have arthritis at some point in our lives. So how do we know when we need surgery for arthritis?
Well, I mean, that's a very good question. And I think I'll start by saying, I don't think we ever need to have surgery for arthritis. I think it's because it's not a life-saving treatment. I think it's kind of a lifestyle treatment. So the number one thing I tell patients is they've got to try all the non-operative treatments available before we talk about surgery. And again, that involves therapy, anti-inflammatories, and sometimes injections. If all of those things fail to provide significant pain relief, and you feel that you're otherwise doing great, the only thing keeping you off the golf course is this painful knee, and the x-rays show that you have severe arthritic changes, then I have the conversations with patients about kind of the role of joint replacement surgery. Joint replacements work very, very well, but like you just said, arthritis is incredibly common. And so we're not trying to do a knee replacement in half the population. We really want to kind of save those procedures for those who have failed non-operative measures and are just very debilitated by their pain.
Okay, thanks, Dr. Parcells. Dr. Shafferts, a question just came in from the audience, and although it's addressed to all the panelists, I think you're probably the most experienced to kind of answer this because it's something I hear quite often also, and it's a great question. And the question is, are compression socks or stockings something the older adults should wear on a regular basis to help with circulation?
Okay, so that is a very good question, and it is a very common question. And I think there is a lot of people who have the wrong, the wrong opinion or the wrong idea in their mind of what a compression stocking is for, actually. So compression stockings are basically to control edema in the leg. They're not going to prevent varicose veins from forming or getting bigger. They're not going to treat peripheral arterial disease symptoms. As a matter of fact, people with advanced peripheral arterial disease should not be wearing any compression on their legs. It's not going to treat arthritis. It's not going to make a nerve problem better if you have spinal stenosis or another neurologic issue. And actually, it may make them more uncomfortable to wear a stocking in those instances. Basically, the word circulation is the problem here. So there's a lot of people that confuse circulation with a vein problem. When you talk to an arterial specialist, somebody like myself, about circulation issues, to me, that means you're talking about arteries. It means you're talking about blood flow. Compression stockings do not treat blood flow. So compression stockings are used to control swelling. Swelling is a sign of venous disease, not arterial disease. So in a blanket statement, if someone says, should I wear compression stockings to treat my circulation issues? The answer is no. If you're talking about patients who have vein problems, then yes. Patients who have large varicose veins that ache, or patients that have swelling due to varicose veins or any other reason, will compression stockings help them? Yes, but I would not call that a circulation problem. I would call that a venous insufficiency problem. So the word here, the issue here is the verbiage circulation. That's a grab term that is used too broadly in too many situations.
Okay, thanks, Dr. Shafferts. Dr. Parcells, I've got a few questions here from the community as well as one of the panelists, as one of the participants, and it has to do with knee surgery. And I get those questions all the time. People, a lot of patients, a lot of family members who are elderly, who due to arthritic knees or at the point where their daily lifestyle has been drastically changed. And people have they tell me I have a lot of old sports injuries. Myself, I have an old football injury in my knee, and I'm kind of just waiting for it to get so bad where I have to have something done. But getting to the point is that I hear a lot of this new robotic surgery for the knee. Things now, we're making use of technology. I also hear coming out of like Sloan Kettering or the Hospital for Special Surgery, muscle sparing procedures for the knee. And a lot of people are so worried about post-operative pain and rehabilitation. Give us, a brief overview here on knee surgery.
Sure. Yeah, I would say that in the last 10 years, there have been a lot of advances in knee surgery. Interestingly, what we end up using as the knee replacement itself, like the metal that's used, has not changed probably in 20 years. But the techniques we use for minimizing pain, for preventing blood loss, and for kind of making sure that we have an extremely reproducible procedure have changed dramatically. And so I love doing surgeries at Monmouth because they do have one of these robots. It's called a Mako Robot. And essentially, this is really new technology. It's probably been around for 10 years, and it's only becoming more and more pervasive in the United States, is that you create a CAT scan 3-dimensional model of someone's knee, and then before the actual surgery itself, you design where the robot is going to kind of burr out the area of arthritis. And so when you're doing the surgery, you actually just use a robotic arm, and everything's been pre-planned, and you're able to very accurately put in this knee replacement. And that's not to say that everybody needs a robotic surgery, but it's a really nice tool, particularly in people who have significant deformity, of their knee associated with the arthritis. So that is a really cool new technology. I perform a couple of those surgeries every single month at Monmouth, and I get patients asking me about it all the time. So it's great.
And what about this muscle sparing technique? Is that something that's caught hold?
Yeah, so that is actually something I do as well. And kind of touching back to what I said before, the challenge in recovery from a joint replacement is controlling the inflammation of all the surrounding muscles and tendons, and kind of getting to work with physical therapy to rebuild the strength and motion. And the muscle sparing technique allows you to visualize the knee to do the knee replacement without creating any injury to the quad tendon. And it does allow for a faster recovery. I think everybody, whether or not you have that muscle sparing technique, is doing really well by 2 or 3 months. But in that initial kind of first few weeks of recovery, I think patients benefit, and that's why I try and do it as much as possible.
Are there patients where you can't do that in?
Yeah, so yes. So there's always pros and cons to everything I think that we do, and the advantage of a muscle sparing technique is that you're damaging less of the surrounding tissue. The disadvantage is that you don't have the same degree of kind of visualization. So if somebody has really severe arthritis or their knee is incredibly stiff, a lot of times doing that technique will prevent you from kind of really being able to see everything you need to see. And so you're able to really determine whether or not you can do it during a preoperative visit. And I still think probably about 80% of people can get it. But those with really, really severe arthritis, or anyone that needs a revision surgery, they unfortunately are not candidates.
Okay, thank you. Dr. Angi, what's the difference between dementia and Alzheimer's?
Okay. So a lot of times people ask me the same question. Do I have dementia or do I have Alzheimer's? So dementia is like a general term. So if I say somebody has fever, I'm just saying the person has elevated temperature. I'm not saying what is that from. Is it from a pneumonia? Is it from a urinary tract infection? I'm not specifying it. Same thing, when I say dementia, I'm basically saying somebody had some global cognitive decline. Their memory is bad, their cognitive skills are kind of affected. So Alzheimer's is being the most common type of dementia that we see. That's only one type of dementia. There are other dementias where you have vascular dementia, where it's because the person had a stroke. That's a different kind of dementia. Or you can have frontotemporal dementia with Pick's disease. Or sometimes we do see patients where it is mixed. They had a stroke, they have some cognitive deficit secondary to the stroke, and they also have simultaneously Alzheimer's dementia. So when somebody says dementia, the next question is it Alzheimer's or something else, or a mixed kind of dementia? So dementia per se, it's just a term which describes memory problems. It doesn't say which kind. Alzheimer's is a specific diagnosis.
Okay, thanks, Dr. Angi. Dr. Shafferts, question from one of our patients is very typical. Patient comes to you and says, Dr. Shafferts, I've been referred to you from my primary care physician because I have vascular disease. I have vascular disease, let's say, of my legs. And I can't walk very far, and it's disrupting my lifestyle. What are my options? What are the different procedures? Or, how invasive is all this? And will I be tied up for weeks healing? And, give us a little synopsis of what the surgery is all about if I need surgery.
Okay, so not many patients are very happy to see a vascular surgeon, obviously, because it usually means that there's something really wrong. And Unlike arthritis, where it's not life-threatening, they start to think that this may be life-threatening or maybe limb-threatening. Fortunately, the majority of patients that we see have mild to moderate disease in the arteries in the legs, and the overwhelming majority of patients can be treated without having to have any type of surgery performed or any other invasive procedure. So the initial treatment for patients with vascular disease is lifestyle modifications, risk factor modifications, supplements, changing their diet, and specifically for peripheral vascular disease, a walking program. So we tried to get patients to exercise, to walk, even though they may have some mild claudication symptoms. And a lot of times we can avoid doing anything invasive by just changing a few things. If they smoke, they must stop smoking, because that is the biggest issue that causes blockages in the arteries. Irrespective of high cholesterol and patients with diabetes and some other risk factors, smoking is the #1 issue in my specialty. So initially, we'll have risk factor modification. We'll have discussions about how severe their symptoms are. There actually are a few medications that I can use. There's a medication called Solostazole, which is called Platal, which is very effective in alleviating claudication symptoms in patients who have mild symptoms. So that is the first line treatment. Beyond that, if patients' symptoms are severe and they really can't walk more than 30, 40, 50 feet, and their lifestyle is very limited by their symptoms, then we have a discussion about how we're going to go about doing something to fix that. Unfortunately, we can't melt plaque from the arteries, so we have to do something to open the arteries up again. Frequently, we can achieve this by minimally invasive procedures, angioplasties and stenting, which can be done just through a percutaneous procedure through an artery in the groin or sometimes even in the arm, avoiding major operations. The problem with these minimally invasive procedures are, unfortunately, that they don't last very long. They last 6 months, a year, and then you may have to repeat them, or you may have to do something on the surgical side. So for the minimally invasive procedures, most of them are done as outpatient procedures, as same-day procedures. Once in a while, somebody will have to stay overnight for safety reasons. But if it can be done percutaneously, there really is no prolonged recovery period. Pain is very minimal, and they can get back to their life within a day or two. If somebody needs surgery, well, that's different. That would potentially be recovery in the order of weeks, not days, and it will take some time to recover from some of the more advanced procedures that we do. If anyone has any specific questions about any specific surgery, that I think we should save for another discussion for another time.
Thank you. We're rapidly running out of time, so I have a few more questions left. I know Dr. Parcells has to leave very shortly. I'm going to ask him one more question. If the remaining questions, if we can fit them in, please be as brief as you can and direct, and hopefully I can get some more questions in. But if Dr. Parcells has to leave, we thank him for his participation. But before you leave, there's one question I want to ask you, and that has to do with, we talked a lot about knee and hip replacements. How long do they last?
Yeah, that's the $1 million question. So first of all, I just want to thank everybody for taking the time to come to this meeting, and I really enjoyed speaking with everybody, and I learned a lot from listening to everybody else talk. With regards to the joint replacements, think of it almost as like the tread on the tire of your car. If you are driving a hot rod and you are driving really fast up and down the highway every day, you're going to burn out those tires or wear out the tread very quickly. If you have a sedan that you're just kind of cruising around town, picking up groceries, doing day-to-day stuff with, those tires will last much longer. So when I talk to patients that are, say, under 55 years old, they're typically, when they have arthritis, they typically have it because they played a lot of sports or, have very active lifestyles currently. And if they need a joint replacement, I do warn them about the risk that it could wear out in their lifetime and they would need a secondary procedure. I would say, though, that for most people over the age of 60, the technology has developed to the point where it should last you your whole life. If you just wanted a number, it's somewhere around like 25 years. But again, like people who are in their 80s with joint replacements, they're not doing a lot. They might be out golfing, but they're not running any marathons. And so those joints really don't wear out very much. And it's so uncommon that I have someone come into my office kind of with a worn out joint at that age. So I think in general, one of the nice things about the advances in technology is that we've gotten better at making these last a long time. So thank you guys again for having me.
Thanks, Dr. Parcells.
All right, take care.
For the remaining panelists, there's a couple of general questions. Whoever would like to jump in, feel free. One question talks about copper-infused socks and gloves. Do they work?
The short answer is yes, in specific circumstances.
Like what, Dr. Shafferts?
So there's a fair number of patients who are on the younger side who are very athletic, like to participate in a lot of sports, and also have some mild symptoms or some mild swelling in their legs when they exercise. It is not an uncommon thing to have some mild swelling of the foot and ankle, especially in the heat during the summertime. And some small percentage of patients do have an element of some mild venous disease in their legs. The copper-infused compression garments are a good over-the-counter compression stocking that can be worn for patients with mild symptoms who are very active. Unfortunately, they do not have a high compression percentage. So compression stockings are graded by how stiff they are or how much compression they have when you wear them. The over-the-counter copper ones can have very mild compression. So they can be used for patients with very mild amount of edema in their legs. And it's mostly patients that experience edema due to increased activity, and especially in the summer months.
But that could be the case with any compression stockings, right? They don't have to be copper compression garments.
No,
So there's nothing special about the copper in the copper-infused garments.
no, it's more of a gimmick than anything else.
That's what I would agree.
Yeah. There's, you can buy an over-the-counter compression stocking
Exactly.
for $20 or $30. Yeah, at CVS or, another pharmacy. But, the copper infused, the copper doesn't do anything.
Right.
As far as the compression is concerned.
So one last question I want to ask Dr. Angi. She can close us out. As we seniors head into the fall season, we know it's going to be a flu season and potentially a COVID-19 season. How do we navigate that? What should we do?
I think the same precautions that we have been doing for the past, 4 or 5 months, avoiding crowds, keeping your hands clean, washing them all the time, wearing the mask, and social distancing. I think it's the same thing. We have the flu shot. I'm sure by like late September, early October, we get the flu shot, and we have to take that definitely this time.
And let me just interrupt you for a second, Dr. Angi, because talking about the flu shots, I just want to make sure all our seniors understand that if you go to the pharmacy and get a flu shot, the seniors should be getting a double dose flu shot.
The higher dose,
Not just the one that they give out randomly to everybody who walks into like a Walmart, not a Walmart, but a Walgreens or a CVS.
That's right. The seniors have a higher dose shot. That's what they should get. In our office, we do it for all our patients, and that's what we carry pretty much. So that's what they should get.
Okay. one last question, and then I promise we'll call it quits. Does glucosamine, I should ask Dr. Parcells this, but does glucosamine help with osteoarthritis?
They used to think it used to help probably 20 years ago, not anymore. The glucosamine, chondroitin sulfate, they used to have those supplements, a lot of people. But there are few patients who swear by it and still take them, but there is no proven data on that.
So there's no medical evidence to support it. Right. All right, well, I'd like to thank everybody. May I'll turn the program back for Andrea or Marybeth to sign us off.
Okay, well, let me just remind you that we are recording this and we'll have a copy of that available for everyone. We'll send you the link. You'll also get the contact info for all of our panelists today.
Yes, and I would also like to thank Dr. Heliotis for moderating the event today and our distinguished panel. SCAN does have a virtual lunch and learn next Friday. The information on that is available on our website at www.scannj.org. SCAN is offering online classes again for the fall, which will begin on September 14th. Again, all that information will be posted on our website. At the conclusion of the webinar, we will be posting up on a slide the physician's contact information. So you want to grab that information today, that will be available. So I thank you all for joining us. Have a wonderful day, and we hope you join us next week.
Okay,
Thank you, everyone.
Thanks, Priya.